Hi there, Dr. Terry Schoenfeld for UAB Department of Medicine. In this video, I'm going to review some clinical prediction rules that are used to estimate postoperative pneumonia and respiratory failure. Now, in two previous videos, I reviewed patient-related and procedure-related factors that are associated with postoperative pulmonary complications. But using those individually is not very useful, because patients may have a combination of different risk factors or different levels of different risk factors. So you really need to be able to put them all together to give a meaningful estimate of postoperative risk. And that's where clinical prediction rules come in. The other observation is that pulmonary function testing by itself isn't very useful as a predictor of postoperative pneumonia or respiratory failure. So these risk prediction tools are much better than relying on testing. And what I'm really going to focus on in this video is what I call the Gupta criteria. Gupta and colleagues developed two prediction rules, one for respiratory failure and one for pneumonia. And I recommend that you download an app if you don't already have it called QX Calculate. And it contains a variety of clinical prediction rules, but we'll have a clinical prediction rule for postoperative pulmonary complications. So what factors are included in these Gupta criteria? So let's first focus on postoperative respiratory failure, which is defined as failing to wean from mechanical ventilation within 48 hours of surgery or unplanned intubation or reintubation postoperatively. So that's what postop respiratory failure is. And these five components are predictive of postoperative respiratory failure. So American Society of Anesthesiology class, the higher the class, the greater the risk. Being dependent, having an emergency procedure, having sepsis preoperatively, and then the type of surgery that you have increases your risk. And this particular prediction rule was published in Chest in 2011. The Gupta prediction rule for postoperative pneumonia was published in Mayo Clinic Proceedings in 2013. Now, the definition of what pneumonia is pretty complex in these studies. Clinically, it's not as useful. I mean, we all know kind of what pneumonia looks like, so I'm just going to leave it at that. And these seven components are predictive of postoperative pneumonia. And interestingly, added to this from the respiratory failure one are age, smoking status, and COPD. And what fell out was that it was an emergency procedure. So these are the components when you do a history and physical examination on your patient preoperatively that you're going to need to look for and document and plug into the prediction rule to help figure out your patient's estimated risk of either postoperative respiratory failure or postoperative pneumonia. Now, there's older indices that have been developed, and it was a colleague of mine, we were Gen Med Fellows together, Gupta and Arozullah, developed one using the VA Surgical Quality Improvement Project databases, and he has two prediction rules, one for pneumonia and one for respiratory failure. I included here. You can see it's much more complex than the Gupta tools. You have to add up all these different numbers that the patients have, look at a table and see what their predicted risk of these two complications are. Now, these tools have been around for a while and I think are useful, but just more complicated than the Gupta tools. So let's look at these two side by side so it can help you decide which one you want to use. So we're going to focus on the Gupta criteria and we'll look at the Arozullah criteria. Both of them were developed from prospective cohort studies, one a National Surgical Quality Improvement Project database, the other a VA Surgical Quality Improvement Project database. They both were developed on lots of patients in a variety of hospitals. Now, the Arozullah indices were developed only at VA hospitals, whereas the Gupta criteria were developed at a variety of community and academic hospitals. Now, the age or the dates of these two indices are different, but really, even though the Arozullah one's getting a little bit older, it really still applies today. Very interestingly, when you look at the data in the Gupta studies, the rates of pneumonia and respiratory failure remain very constant over this time. So I think the Arozullah criteria still apply today. The outcomes we've already looked at, respiratory failure and pneumonia. The C statistics I think are very similar. Even though the Gupta one looks a little bit better, clinically that's not going to be very important. And to remind you, a C statistic is an overall measure of discrimination, meaning if you have a patient with respiratory failure or with pneumonia, and you have another group of patients who don't have that, will the tool be able to accurately classify those patients as having disease or not? A C statistic can range from 0.5, which is useless, like a coin flip, up to 1, which would be a perfect test. You can see where these fall. I think the important thing that differentiates them is the limitations. They both essentially didn't collect any data on sleep apnea, asthma, or include any information on PFTs. And I think the only thing that's important for both of them is the sleep apnea component. We're learning that obstructive sleep apnea is a very important predictor of postoperative complications. So neither of them have that in it, and it remains to see how important that is. I think the most important thing is that the Arozullah criteria were only developed in veterans, and there are very, very few females in those studies. So I think that's an important limitation for using those tools in other types of patients. Also, the surgeries were classified on incision site, not the organ involved in the Arozullah criteria. So what that means is a very complex liver resection would be looked at very much the same as a simple, uncomplicated cholecystectomy. So I think that's a problem, whereas the Gupta indices look at the organ that's involved in the surgery, not necessarily the surgical site. Now, one thing, I've tried to show you that the Gupta indices are slightly better, have a slightly better predictive performance, probably not all that clinically important. It is more surgery specific, which I think is important, and it's a little bit more contemporary, though probably not that important. I think the bottom line is Gupta is much easier to use. There's an app for it. There is no app for the Arozullah criteria. So I think it just comes down to, I like the Gupta ones just because they're easier to use. But I think importantly, just become familiar with one model and use it regularly.